much, Professor Sewan Campo. Session Chair, I want to quickly say a big thank you to the conference organizers for giving me the opportunity to come back home and present to you today. I recognize conference chair and co-chairs. I recognize the acting executive secretary of UNCST and all other relevant leaders today. I chose to give this talk on achieving the 717 target because Uganda has contributed so much to a framework that is reshaping the global health security landscape. A lot of the ideas that the world is using today related to this framework comes from actions that were taken in Uganda, operational research conducted in Uganda, and advocacy for Uganda. What is global health security? It's a collective effort. Countries, member governments, they have that responsibility to protect their citizens, which means led by countries, but also organizations and communities. And the intention is to prevent, detect, and respond to infectious diseases threats. This could be natural outbreaks, as we know commonly, but it could also happen due to the release of pathogens, whether viruses, bacteria, whether accidentally from laboratories or intentionally through acts of terrorism. Maybe this is better. It's important that we listen to our elders. And Nelson Mandela set up a group of individuals who were supposed to come together and advise global institutions in relation to world peace and development. And one of the elders is a lady called Gro Harlem Brundtland. Some of you might know she was the World Health Organization Director General in 2003 when we had the SARS outbreak. At that time, she confronted challenges getting information from the countries that were affected due to a lot of secrecy around the start of the outbreak. And it took many weeks before the organism was actually confirmed to be SARS-CoV-1. 2019, after campaigning for more than a decade, she gave a talk on global health security. And she listed several things that were problematic. She mentioned that there were alarming gaps in preparedness, and that leaders of all countries would need to take charge and close those gaps. That leaders must invest in universal health coverage. That is, people can access the care they need without ending up in poverty. Everyone can access that care that they need without falling into poverty. And she believed that universal health coverage was the best approach to close all the gaps that we have in our health security system. So it's really important we keep that in mind, that when we think of health security, we're often thinking of people running in vans and, but the WHO DG said if your health system is functioning, primary health care level, everybody can access the care they need, then you actually start to fix all the chains, gaps in all the chains for health security. The last point she thought that people should focus on was multilateralism. Individual countries not saying, this is my outbreak, I'm going to handle it the way I want, I don't care what anybody else thinks. But really for all countries to come together and say, when we protect our citizens from our outbreak, we're also helping to prevent spread across borders, and we can work together and cooperate, not just on the response, but also on some of the benefits that might come out from those, including things like drugs and vaccines. And Uganda is located in the Congo Basin. So some of you might have heard that advert from like 20 years ago. It was Uganda gifted by nature. How many people remember that advert? It used to be on CNN. But being gifted by nature means that you have a wide number of animal species, but also a wide number of pathogens that live in the ecosystem. And one of the animals that we need to be concerned about, or to at least think about, are bats. Bats are located in many parts of Africa. They've developed a way to survive even with dangerous pathogens. So Ebola has been detected, found in bats, Marburg has been found in bats. They don't fall ill, but the virus is there. And some researchers have suggested that it's actually at the time when they are in breeding season. They've just given birth and there are a lot of secretions in caves that people stumble into these locations and might get infections. Now these are realities of the environment. But people can intentionally move into animal habitats and say, hey, I want to farm there, or I want to cut down that tree, and sell it. So economic pressures and migration is also pushing us to a state where we have what we call zoonotic spillover. One thing that Brundtland mentioned was that we have the tools. We know what to do to develop a therapeutic. We know what to do to develop a vaccine. We know what to do to develop a diagnostic. The diseases listed here are not special in the sense that it is more difficult to develop a therapeutic, a vaccine, or a diagnostic scientifically, but they are different in the sense that because they don't happen all the time, there really isn't an economic incentive to do so. So if you made an Ebola drug and you invented it and maybe you spent $1 billion, you might wait a decade to get your first patient. How do you make your money back? There have been disincentives for the development of drugs, vaccines, and diagnostics. And only political leaders can take charge and say, even though it's not going to be profitable, we want this in our stockpile. We talked about the gaps. How do countries check to know whether they have gaps? And the International Health Regulations is an agreement, it's a framework that all countries sign up to when they join WHO. And they make commitments. One of the commitments is that every year they will assess themselves to identify gaps in their health security system. That's mandatory. And around this time of the year, the Ministry of Health is starting to fill out their forms. But every few years, countries can voluntarily open their systems up to external review. WHO comes in country, other peers, other countries will also come and really look at the gaps that are present in country. When you generate that report, you call it your Joint External Evaluation Report. WHO can then highlight what you can do to close the gaps you've identified. And there is a tool developed also by Resolve to Save Lives in collaboration with WHO that shows what you need to do to close the gaps that were identified in your evaluation. And if you look at that, if you were not alarmed before, you probably start getting alarmed now. Uganda still has 444 actions to complete. This could be training of certain groups, it could be development of SOPs, it could be implementing laws. There's a lot of work to do. And yet, Uganda is considered one of the best prepared countries in Africa. So do you feel safe? So if you're not feeling safe, then, I hope the rest of this talk is helpful. So, if we changed it, let's flip the script. If rather than saying these are all the gaps that we have, and we have to cover and close all these gaps, and we know we don't have the money, we know we don't have the time, we know we don't have the bandwidth. What if we did it a different way? What if we said that let's use every outbreak we have encountered in our system as an opportunity to learn what works and what is failing in our system, and then fix that and keep doing that with every outbreak continuously. So 717 was actually developed for that same specific objective. A systems-based approach to improve the speed of outbreak detection, notification, and response. And so the first thing we talk about in 717 is time. And why are we interested in time? The faster you can get to the outbreak, because outbreaks have exponential spread. So if you catch it early, you're catching it when it's still small. And so 717 is really assessing how quickly do you detect, notify, and respond to the outbreak. But you may or may not meet your target in terms of how quickly you wanted to catch the outbreak. So you want to find out what slowed you down. And those are your bottlenecks. And once you find the bottleneck, you want to do something about it. If you can do something about it immediately, you take action immediately, or else you will put a plan in place for resolving that in due time. And so what does 717 really mean in practice? It means that every suspected outbreak is detected no more than 7 days after it emerges. So no more than 7 days after it emerges, you know that there is something suspicious about the situation. Either that's a patient presented in a facility, a community death, a cluster of animal deaths. You know that something has happened within 7 days from the time it emerges. The second is 1. This time to notify is a maximum of 1 day to inform the public health authority responsible for taking action. And that might be your district head, it might be your national EOC. You need to inform the right level immediately. And then, what 717 also brings is that you want to complete early response actions, those things that need to happen to contain an outbreak. And those need to be done within 7 days. Now there's a list of 7 actions here, from like sending out your rapid response team to collect information about the outbreak, doing your initial analysis of the data they bring back, sending samples to the lab and getting a confirmation of what it is, the public health lab, providing care to patients safely, giving appropriate public health countermeasures to stop further spread, providing clear and appropriate information so that people make the right choices, and then having a coordination mechanism to ensure that everything that is happening related to the outbreak is well known, well resourced, and safe. And the bottlenecks, as I said, these are the barriers or the challenges or the obstacles that delay. And the enablers are processes, systems, or relationships that might be in your system that can help you, to have prompt detection, notification, and response. So once again, you start off by collecting the timeliness information. Are you early or are you late? You identify your bottlenecks and enablers. You determine which actions you can do immediately, what needs to stay a bit longer, and then you start to see if there are patterns in the way your system performs when new outbreaks come up. Are you always seeing laboratory confirmation challenges? Then put money in your lab.
Are you always seeing a delay in sending out rapid response teams because funding is not available for immediate deployment? Set up a rapid outbreaks fund. So when you start to monitor the pattern and look at the progress that you're making, you can then start to see some of the system improvements. So we use it for three things: performance improvement, but we also use it for advocacy. You can find out that a specific area faces more challenges than others, and then you can also use it for accountability. If you set up your national EOC, your national EOC manager should be able to tell you, of the 50 outbreaks we've had in the last 3 years, we were able to meet the target 4 times, we were not able to meet the target the rest of the time. So although it was piloted in Uganda and a few other countries, up to 20 countries are now using 717 routinely in their system. But even more countries, about 40 countries, are part of a community of practice that meet regularly to discuss how to best implement 717 in their public health emergency systems. And that's interesting because, as I said, for many countries, talking about challenges related to outbreak management had always been handled in secrecy, within their countries only, within authorized communication channels. But that is changing now, and countries are sharing experiences on what to do to move faster and stop outbreaks before they become epidemics. Beyond that, global frameworks have all started to adopt the 717 approach, whether that's WHO in its own strategic plan, or WHO guidances that have been provided, the US Global Health Security Strategy, and major funding mechanisms to help countries strengthen their health security systems, the Pandemic Fund and the World Bank, as well as the Global Fund, all use 717 to track progress and impact. Now, what created all this energy around 717 was actually an Ebola outbreak here in Uganda that caused the world to stop and say, wait, we need to take this seriously. And I'm very glad that many people here in this audience were actually part of that response, and many at least understood what a significant threat it posed to Uganda. It took 46 days. We didn't know it took 46 days during the response. It was much later, after the case investigations went on, we found out that it took a minimum of 46 days for us to recognize that we were having a problem. There were community deaths, but potentially because of COVID fatigue, where community deaths were also happening, the clusters were not picked up on time. And it was really surprising because typically within 14 days, Uganda would detect some of these issues that happen at community level. There was also an issue because private facilities, people would present at private facilities, and then they'll be treated, and then they'll move to another private facility and get treatment again, and the health workers would not recognize. One of the challenges there is that private facilities were not included in the trainings on case definitions, what outbreaks look like, that the government had been rolling out at the time. There were also challenges in response. At the epicenter, the isolation unit was not functional, and in the initial period, people had to be moved from Mubende all the way to Fort Portal, later to Entebbe, before Mubende's treatment centers were constructed. There were also issues around delays in accessing funds for rapid outbreak investigations and contact tracing. And all of these information that you see here was shared with the WHO. The country didn't hide anything. It says, look, these are the challenges we encountered. We fixed them along the way and managed to bring the outbreak to an end in less than 4 months. If you fast forward to 2025, Uganda had the same type of outbreak, Ebola Sudan, earlier this year. But by this time, Uganda had implemented mortality surveillance. People were to die, they test, and that helped to pick the first case this time. The government was able to institute rapid contact tracing, even without external support or partner support. And because of the challenges the first time, they were able to pre-position protocols and stockpiles of investigational vaccines. I'm grateful the principal would will be part of us at some point. I think he'll be able to talk a bit more about some of the investigational vaccines and how they were used. But critically, some of the knowledge that had been used in the past for investigational therapeutics were still applied in this outbreak. For the first time, we are reporting that everybody admitted to the treatment center was discharged alive. Those are the kinds of changes that you can only see when you're actually learning from every outbreak. Now, this is a bioethics conference, not a response conference. And there's some things that I would say that kept me thinking during that response. And I'm hoping that people might have some time to think through them and come up with perhaps recommendations that the country can use. We used institutional quarantine, and it was important because it prevents spread to other people in the community. So you bring people that have been in contact with someone who has Ebola. They don't at this stage have Ebola, but you want to observe them for a period of time to see if they develop symptoms. So that sounds perfectly fine, right? It's a good intention. But when you put them in a group and there are other people that you're also monitoring, there is a chance that one person develops Ebola, and then the ultimate tragedy is that somebody who never had the infection but was quarantined in a space actually contracts Ebola from somebody else. And because of that risk, in some countries, in DRC in particular, some partners have recommended that they start to use community quarantine. You stay in your home, and then people watch you. That way, we check to see if you're getting sick, and then if you get sick, we move you out. The challenge, of course, is that people may escape, difficult to find, and continue spreading the outbreak. So what's that balance between institutional quarantine and community quarantine? And I think that from the last outbreak, we started to see a potential benefit. Those people that were in institutional quarantine, as soon as they developed symptoms, were moved directly to a treatment center and started to get their treatment right away at the earliest stages of their disease, and they appeared to do better. The other thing that I think we need to talk about is healthcare worker protection and duty of care. You can't be 100% certain that somebody who has a mild fever and no other symptoms does not have Ebola, for example. So we use standard precautions when we approach all patients. But standard precautions may not be sufficient if you're working in an ICU. They may not be sufficient if you're conducting a surgery on that patient, right? And so we still see situations such as the Marburg outbreak that happened in Rwanda, where health workers working in intensive care units got infected. In fact, it was an explosive outbreak. Over 55 healthcare workers within the first week of an outbreak were already infected. So as our care advances, as we start providing more advanced care, more interventional care, more access to surgery, we have to know that there is a potential risk that patients that don't meet the case definition will interact with healthcare workers, and that can lead to outbreaks. In the 2022 outbreak, there were about 6 healthcare workers that operated on an individual the day before the outbreak was announced, so they couldn't have known that there was an outbreak, and they unfortunately got Ebola spread. Investigational therapeutics, this was a challenge for me because I was in the case management. When you're working with a disease that doesn't have an approved treatment, everybody is scratching their heads on what to do next. In the case of this, you had to decide whether you were using compassionate use, that is, doctor decides, this is really good for the patient, patient decides, I want to try that, regulator says, I'm not going to object. You can have those kinds of mechanisms. But WHO came up with what it calls MURI, which it said was not research, it's monitored use of unregistered and investigational interventions. And the reason why that was developed was because they felt that it would take too long to do a clinical trial, and yet you wanted to get valuable information about the outbreak while the outbreak was happening. And if you waited until your clinical trial was set up, the outbreak would end, and then you have to wait for several more years for the next outbreak before you can do anything about learning about that outbreak. For monitored emergency use, when you develop your protocols and you collect your data, it starts to look like research. And when we presented those protocols to IRBs and UNCSD, they were treated as research. And so the benefit of having them quickly approved and used was actually lost, because there are elements in Murray that actually look like research. And an ethicist wrote a paper just a few months ago. She says, if it quacks like a duck, it's probably a duck, right? Now, clinical trials are the gold standard for us to learn about what works or what does not work. In the past, you would say, this is response, and then clinical research is a separate issue. But now, we know that if you're going to do the response and you have no treatments, clinical research is actually part of the response. And I think that it's really important that we have pre-positioned protocols, protocols that are already approved, protocols that are approved even if we're not entirely certain about the particular intervention that would be used, but at least we understand the technology. I think those are the things that will help us to make sure that for every outbreak that happens, we gather the necessary information to know what works. And the same thing goes for investigational vaccines, in addition to the usual things around vaccines as to who should get it and who should not. Misinformation is perhaps the biggest threat for public health. And people have freedom of speech, right? They can say what they think. How do you go, figure out whether this is just misinformation or whether you're now moving into, disinformation or outright deception? And unfortunately, there are groups that seem to be focused more on disinformation. This is difficult to see, but I put it here because we want to meet that 717 target 100% of the time. For every outbreak, we want to know we detected quickly, we notified quickly, we responded quickly. And this was a paper of about 41 outbreaks. And for viral hemorrhagic fever, people met, the outbreaks met the 717 target half of the time, 55% of the time. But I want you to look at vaccine-preventable diseases. None of the outbreaks met the target. Food, waterborne diseases, none of the outbreaks met the target. Why is that happening? Do we think that vaccine-preventable diseases are mild? Or are we not so worried when it's a food or waterborne disease? I mean, even vector-borne diseases only had about 20% of events meeting the target. And that means that we can actually look by disease and figure out and say, where exactly are we failing? And then invest in improving systems for those diseases. This is another paper that was published just 10 days ago or so, less than 10 days ago. And this looked at outbreaks that had happened in Uganda, 84 outbreaks that had happened in the past in Uganda. And this was one of the first studies to show that if you detected early, so an outbreak emerges and you detect early, that you'll have smaller outbreak, fewer people will die, and a shorter duration of outbreak. Many people will say, that's obvious. It's obvious, but have not been documented. And so more information for the rest of the world to see that we need to detect faster if we want to keep our outbreaks small and to reduce morbidity and mortality. Now, what can help us detect faster? I cannot stand in the EOC at the Ministry of Health and know what is happening, in a small community around Google. Somebody has to be there to tell me that we think something is wrong. And primary health care is potentially the opportunity we have to really spread our eyes and our ears throughout the community so that when something untoward is happening, there's somebody who is trained and can report. Of course, there are many primary healthcare facilities, and training everybody in primary healthcare is considered very expensive, and many people say, forget about it, we don't have the budget. I want to show you this opportunity, and this is a project that's been happening in Uganda for about 11 months, but also in Ethiopia, Sierra Leone, and Nigeria. And in this project, what was done was they would use a mentorship approach that was actually developed in Uganda, where you go to check on health workers in primary healthcare facilities and see whether the IPC systems are effective. But they integrated on top of that, checking to see that health workers knew how to notify, to recognize and notify if they saw an outbreak-prone disease. Now, through that project, they used mentorship, they used the mobile phone for training on case definitions, and then they would send a mystery patient, maybe once in a quarter. Somebody goes to the facility, and then you see how the facility responds to someone who might have had an outbreak. After the person is, you do a debrief with the entire facility, and everybody knows what they could do better next time. And these are the kinds of data that we're seeing, right? When you do that, when you work with your primary healthcare system, 90% of all outbreaks met the first 7, the detection target. 100% actually met the notification target. And health workers did some surge actions for which they all got relatively high scores. So even though we think that these are impossible, they are challenges that are too big to overcome, the evidence that we're seeing, whether you're in Ethiopia, you're in Nigeria, whether Uganda or Sierra Leone, health workers at primary healthcare level, once oriented, are able to intervene and notify of outbreaks very quickly. So who is the 717 Alliance? It's funded by Resolve to Save Lives, which is an international NGO that focuses on trying to improve outcomes from outbreaks and other non-communicable diseases. But the 717 Alliance is an initiative to help countries create a space so that countries can have this conversation that we're having today. What is working well in our system? What is not working well in our system? What can we learn from other countries to improve? And we've been providing technical assistance, small country grants, as well as tools and resources. And through the Wellcome Trust, we provided funding to different researchers in the US, all the way to Asia, to support generating new evidence around the implementation of 717. We've also reviewed how we work. And if you go to our website, 717alliance.org, you will see our own evaluation of how we interacted with countries, what we did well, what we didn't do well in terms of scaling. And the interesting things is that you start to see those same issues: leadership, funding, implementing for your local context, having enhanced capacity building approaches. And these are the key learnings that come up when a country tries to institute a performance improvement approach like 717. Now, if you want to read more about the things that really keep us slow, we put briefs. One brief is on low clinical suspicion, which I've talked a bit about today. The second is on delayed lab confirmation. We have some lab tests, and I know there are some lab people in the room, where you actually need 2 weeks before you get your result, right? You're waiting for like an immune response. And so you systematically miss the target because of that type of diagnostics. What are we saying at 717 Alliance? We need better diagnostics for those things. And then issues around lack of resources for rapid outbreak investigation, as well as solutions that really are available for countries to consider. We also run something called epidemics that didn't happen. If a country intentionally puts efforts to stop an outbreak at the time which is very small, that is actually something that should be recognized and celebrated and not ignored as it currently is. And so we have case studies where we show that rapid action stopped transmission of outbreaks and stopped them from becoming epidemics. And with that, I say a big thank you to all of you for your attention.